So as we see, inverse ratio ventilation had a lot of great things to offer, but it had a lot of bad things too. So along came APRV. This mode allows us to get the same benefits as inverse ratio ventilation without some of the complications. Basically what they did is they put a release valve into the system, and that valve basically allows the patient to spontaneously breathe through the entire inspiratory and expiratory phase of ventilation. While this mode may still be somewhat uncomfortable to the patient, it is nowhere near as uncomfortable as inverse ratio ventilation. In fact, the use of paralytics are no longer necessary, thus it makes this a very nice option when it comes to mechanical ventilation. In fact, this mode is now more like interrupted CPAP, which again, I'm going to explain that a little bit later. Let's talk about a few of the misconceptions about APRV. There are a few that exist. First, many believe you still must allow for the permissive hypercapnia just like you did in inverse ratio ventilation, and this is not necessarily true. Remember, the patient can now spontaneously breathe, so the CO2 can usually be kept at normal values. Even if they are not spontaneously breathing, you should still be able to keep the CO2 within normal limits. And I've been doing this mode, like I said, for over 10 years, and in most of my patients, I can keep the CO2 exactly where I want it. Now, there are exceptions. There are some patients that are simply so sick, they're producing more CO2 than we can possibly blow off. And there are other complications, obviously, as well, that could lead us to not being able to get the CO2 blown off the way we want. But in most of the cases, I can cover this. I can get it taken care of just the way I need it. And we're going to cover more about how to accomplish this later as we talk about setting changes that can be made for optimal blood gas results. Because remember, ultimately, anytime we're talking about mechanical ventilation, our job is to make sure that we're achieving ultimate blood gas results for our patients. Another common misconception is that we can't use this mode on patients that are diagnosed with COPD. Now, this is not necessarily true either. Now, the reason that people make this claim is because COPD patients typically require a longer expiratory time than normal due to the disease process that's affecting their lungs. However, we must remember that not every COPD patient is the same. Not all of them have an extremely prolonged expiratory time. I have used this mode on many patients with COPD, and most of the time it's worked just fine. In fact, I can count probably on one hand the amount of COPD patients where it wouldn't work with. Now, sometimes I had to have a longer expiratory time, and my ID ratio was not as desirable as I would like, but it still can be done. If you have a patient with COPD on the ventilator, and you think that they can benefit from this mode of ventilation, then you need to give it a try. Until you try this mode on your patient, you're never going to know if it works for them.
P high. This is the inspiratory pressure, or the amount of pressure that the ventilator is going to deliver during the inspiratory phase of ventilation. So what's going to happen here, your peak inspiratory pressure, the pressure you get back from your patient, is going to be the same as your P high. It's a constant number, similar to pressure control. Okay, so the inspiratory phase, whatever I have my P high at, that's what it's going to be. P high is adjusted in order to get a certain tidal volume. So if you go higher on your pressure, you're typically going to get a larger tidal volume. If you go lower on the pressure, your tidal volumes will be smaller. P low or PEEP, depending again on what ventilator you're using. P for P low, of course, stands for pressure. So it's the amount of pressure that's going to exist during the expiratory phase of ventilation. Typically, you set PEEP on just about every single mode that there is. So during the expiratory phase of ventilation, the baseline pressure is going to be wherever you set your PEEP. Now, in this mode of ventilation, you typically don't set PEEP. All right, in the true APRV version, you can't set it. Okay, just something to keep in mind. T high. Well, if P stood for pressure, then T must stand for time. That's basically what this is. It's the inspiratory time. Normally set between 3 and 4 seconds. A lot lower maybe if you have an infant or neonate, probably just 1 or 2 seconds. But basically this is the amount of time. Remember we talked about P high. During this time, this inspiratory phase, it's the amount of time that that high pressure that we set will be delivered to your patient. And last but certainly not least is the T-peep or the T-low. Again, T standing for time. This is actually one of the most important settings that exist in this mode of ventilation. Okay, it's the time that you're going to be spending at that low pressure or PEEP, which of course, if we set it at 0, it's the time we're going to be set at 0. Now, the reason why this gets very important, if we're not setting PEEP, then we need to create some form of auto PEEP with our patient. We'll be getting to that more later in the next video. Okay, so you have a proper auto PEEP, you usually have to have this T-peep or expiratory time very low. Typically 0.5 to 1 second, but we'll get into that a little bit more as well as we go along in these videos. Okay, this is probably the shortest video that I have created. The next section gets more in depth, so it's probably going to be a little bit more deep, and so I want to devote a little more time to that. So this is the end of part 2 of APRV. Once again, as usual, there's other places you can find all kinds of good content. www.10ceU.ning.com. You can go on there. That's our social media platform. We have all kinds of blog posts. We have interactive discussion forums and links to all of our other videos. So you want to check that out. It's all free. The goal of this business is to provide as much free information as humanly